Okay, hi. Hi everyone. My name is Jonathan. This is the first time I'm presenting this GHAPP MASL MASH Community Network series. Um, I am presenting today a case three. It's all about lifestyle management of our MASL MASH patients. Again, my name is Jonathan Ye. I'm a PA. I work at the Center for Liver Disease and Transplantation at the Columbia University Irving Medical Center in New York City. I've been doing this for the past 14 years. That is treating liver disease and caring for pre-transplant patients, and I'm loving every minute of it. So you can use this QR code to register for this meeting, whoever out there is not registered. And also you can use this QR code to visit the GHAPP MASL MASH Community Network to view Madrigal MASH disease state education and Madrigal's Restifra promotional program, which means that if you want more information after you listen to today's presentation, you can just go there and look for more information for your own consumption. Okay, now today's case, clinical case study, we are looking at Albert, who's a 65-year-old male with obesity. I don't think he's really obese, especially on the BMI 29, which is overweight. But anyway, he's told to be obese and is referred for elevated liver enzymes and abnormal imaging with abdominal ultrasound. That remarkable for increased echogenicity, consistent with the steatosis. What is this laboratory study? Let's look at it. We have triglyceride at 89, HDL at 41, and with an A1C of 7.2%, ALT with known elevation for 3 years, hovering between 1 to 2 times upper limit of normal. Evaluation of other etiology of chronic liver disease were all negative. He does not, or he had alcohol's history before 20-year-old or in his 20s, which is about 40 years ago. And his medical history includes type 2 diabetes, hypertension, hyperlipidemia. These are all components of a metabolic syndrome. Physical exam findings include abdominal adiposity, but there is no stigmata of advanced liver disease. His BMI is 29, which is by definition is overweight and approaching obese status, which is BMI at 30. Okay, now I preliminary diagnosis, or as we call it, a working diagnosis, would be metabolic dysfunction associated steatotic liver disease, or used to be known non-alcoholic fatty liver disease. Okay, but now we use MASL, uh, metabolic dysfunction associated steatotic liver disease, or with the inflammation form of which will be called MASH, will be called steatohepatitis. Now, let's dive deeper into Albert's lab or workup. Well, he's here listed ALT, AST, and platelet count of 170. With his age of 65, this conveniently help us calculate to get a number of FIB4 of 2.22. Now, based on the scale, this means that he has indeterminate risk for advanced fibrosis. Now, what would you do next? I would do a fibroscan. But usually at this point, um, oh, I forgot. I'm the tertiary center. So when this patient is referred to us, I would do a fibroscan. At the same time, I will order a blood test of fibrosure. So in this case, and for this presentation, Albert got a fibroscan with a 6.7 kilopascal, which again shows low risk for advanced fibrosis. Now, based on the guidelines, the management would include lifestyle modification, metabolic disease management, and follow up to repeat non-invasive testings, NITS. Now, okay, let's talk about MASLD, or the metabolic dysfunction associated steatotic liver disease, the continuum, or in my mind, I call it just the progression of fatty liver disease. We're looking at patients who usually has overweight, obesity, and or type 2 diabetes, plus minus two or more metabolic dysregulations, or two or more metabolic risk factors. So type 2 diabetes, overweight, already two. And I believe he has hyperlipidemia. So in Albert's case, he has three risk factors. But just for the sake of talking about the progression, we know that on the far left, there is a steatotic liver with a fatty liver, may progress to steatohepatitis, which is MASH. It's reversible at this point, and with the steatohepatitis, it's very easy and unpredictable how fast the patient would develop advanced fibrosis. But even so, its advanced fibrosis is still reversible, can come back to very little fibrosis and just a simple steatohepatitis, and may go back to just simple steatosis. What's missing here is that steatosis is also reversible back to a normal liver. Now, we can see also during any of these four stages, hepatocellular carcinoma or liver cancer may pop up to haunt the patient. Little bit interesting facts about the risk factors and pathogenesis. Now, as we all know these days, that most of the human disorders come from genetic disorders. So in this case, there are the slides listed a few of the major genetic variants that promotes abnormal accumulation of fat in the liver, and development also implicated in the development and progression of MASLD. Plus, so in addition to these genetic variants, which they all, I did not talk about this, but yes, all these genetic variants, they all promote one thing, one basic thing, abnormal of fat accumulation in the liver. Now, in addition to these genetic defects, consumption of saturated fats, fructose from soda and sugary beverages, and excessive dietary fat all will contribute to a steatotic liver, which give an opportunity to develop into steatosis, inflammation form of steatohepatitis, which is MASH, and may lead to cirrhosis. Okay, now this slide, it looks simple, but it is simple. So for me, just to sum it up, type 2 diabetes, obesity is heavily or frequently associated with a metabolic dysfunction associated steatotic liver disease, MASLD, and may develop into MASH. How do we manage them? How do we counsel the patients when we talk about lifestyle modification? So you often counsel the patient on the balance between nutrients and energy, uh, because these are crucial in the development of MASLD and MASH. And what about central obesity? That's something we need to drill into the patient, that it is a major promoter of insulin resistance and pro-inflammatory signaling, which will usually will change MASLD from MASLD to MASH. Okay, back to Albert. Now, as we continue the visit with Albert, during the dietary survey, Albert explains that he eats a traditional Cuban diet consisting mostly of rice, beans, pork, beef, and plantains. So as we can see here, even though it looks pretty balanced, there's protein, vegetables, fibers, and carbohydrate. So how can we best discuss diet with our patients? I have to tell you, it looks and sounds easy, but it's not. Most of my patients would have a hard time giving up a carbohydrate, especially the refined one. We ask them to avoid. And then we also go to how do we tailor dietary recommendations to cultural preferences and food accessibility, socioeconomic status. I think I can spend a little more time on this. This would also at the same time answer the question about how can we best discuss diet with our patients. So I go to several outreach offices. So at my main clinic, I see regular American patients who, when they come in for a MASLD consult, they really need to try to give up um, pasta, noodles, and white bread. Then what about in one of my outreach office, where I see mostly Asian patients, whose diet are primarily of rice and bread, and there are also some dumpling and doughy food items that that made out of white or refined white flour. So for those, I have to tell them, for the Asian population, I have to tell them to avoid products or food items made of refined carbohydrates, such as white flour. The problem is what do they eat to replace this? These things such as white rice, white bread, and white noodle, because these are their main part of their diet. With that, they consume a little bit of vegetable um, and proteins. So it's contrary to what we perceive as a healthy Asian diet. But when we talk about these main food items, we can touch upon green Mediterranean diet, which we'll talk about a little later. So that's what that's what I'm about to talk about, this dietary recommendation based on culture preference and food accessibility, socioeconomic status. Again, the diagnosis is MASLD. Okay, so more about lifestyle modification. So in terms of dietary change and exercise, when we talk to our patient about, um, patient has to know that these two, dietary change and exercise, has been the mainstay of MASH and MASLD treatment prior to resmetirom medication approval. But even with the resmetirom approval, it's still and exercise is still a big component of the total treatment. Now, what about weight loss? And weight loss was directly linked to improve the histologic outcome when we counsel patient. So losing 5 to 10% of the weight may resolve steatosis, MASH, or any, and also can exert antifibrotic effects on MASH. So the patient with MASH may see a regression of their fibrosis status. Okay, again, about lifestyle modification. Here we can look at the top part of the circle. A patient that is avid exerciser doing aerobic and resistance training, and they eat a Mediterranean diet. They usually will lead to healthy liver. And the bottom part showing patients consuming on a Western diet and a sedentary lifestyle. This will usually lead to fatty liver and or steatohepatitis. It leads to MASLD and MASH. Actually, before I come in here, let's talk a little bit more about the Mediterranean diet, and this has something to do with our Asian patients as well. So for Mediterranean diet, the patients are counseled on eating more vegetable, fruits, and whole grains. And these can replace the white rice and white flour made the food items. And also the nuts will help with the sensation of fullness and also promotes healthy living. Now, here we are looking at high intensity interval training, which was recommended by us a few years ago until a study shows that high HIIT is not as effective as aerobic and exercise and resistance training in terms of weight loss and reducing and improved healthy liver. So on the right, the diagram shows that aerobic exercise and resistance training can improve the liver condition from fat in the liver, fatty liver, to a normal liver. Then here again, we talk about the dietary help in calorie restriction to achieve weight loss is the mainstay. Then what about the promotion of ketogenesis, which is what low-carb diet can bring about? So promotion of ketogenesis is promoting the conversion of fat into energy. Now, genetic disposition or personal response to a specific diet is not clearly understood, but the basic, again, the mainstay of avoiding carbohydrate and the refined carbohydrate can almost help everyone, patients with a MASLD diagnosis. And what about the Mediterranean diet? We're here again, which is supported by ASLD, AAC, and European guidelines as a recommended primary lifestyle intervention. And again, Mediterranean diet is rich in vegetable, whole grain foods and nuts, and with olive oil. And I actually, after reading some study, I also recommend a cup of green tea, a brewed green tea, which promotes the health and improve the condition of MASLD. Now, Alper returns to routine follow-up now with no improvement of labs. Why? He admits that he has not begun any exercise regimen, but has been trying to cut out soda. Yeah, well, obviously he's trying not hard enough. So what do we tell them to do? So we have to tell them to work harder in terms of lifestyle and modification, more exercise, definitely cutting out soda, and has to change his diet to be more like a Mediterranean diet, to cut out the refined carbohydrate, white rice, go with round rice, brown rice, or whole grain rice, things like that, and a more aerobic training, even an hour of walk, a brisk walk, 3 times a week, can help achieve the goal. So how do we work with patients to create behavior change? Uh, that I don't know. I've done my part. I oftentimes refer patient to nutritionist for a nutritional consult. Some patients do it, some patients don't. So it really based on patient's motivation. And I have to learn more about the motivational tactic or skill, but I hope just by constant reminding them, we'll achieve the goal. But that's just a hope. Um, One of the tools which was not widely used is the Exercise and Diet Adherence Scale, or EDAS. It's some practitioners complain it's too long. Sometimes it takes too much time to complete. But no matter what, it's voluntary. It's a questionnaire at baseline and at 6 months visit. It's a 33 question. It says criteria or question checked to monitor daily exercise and calories intake. I haven't used it before, but we talked about using it in our clinic. Okay, thank you for your attention, and I am open to any questions today.